Sure, thanks, Pat. So I have a presentation that really goes through the new CDC guidance for schools. There is an accompanying science brief with it that talks about, how they came up with the recommendations. Guidelines are pretty straightforward, pretty well done. There's a few things I feel like they're a little gray. One of them is I really want to stress that the key to these guidance are to keep kids in school. If you look at the first few paragraphs, it's all about keeping kids in school, focusing on in-person learning, lowering the burden of COVID on schools so schools can focus on education. It's not to test people and count numbers and make people do things. It really is around keeping kids in school. So let me start my presentation. There's a few of these I'll go through pretty quick, but just wanted to give everyone an overview.
Great, thank you, Ted. It's 28, August 28th. Thank you, everyone.
Screen 2. All right, here we go. Hopefully we can see our screens. My screen. So CDC, a week ago Friday, did put out new guidance through K through 12 schools. Again, these are recommendations. There's only kind of one thing in here I'll really put out that's point out that's a requirement. So like I said, I want to highlight this again. The key takeaways, if you look at the very first one, students benefit from in-person learning and safely returning to in-person instruction. That is a priority for fall of 2021. The key takeaways are really well written, and they go through the key points that I will go over next. American Academy of Pediatrics just put out guidance yesterday. I want to point out here as well that for theirs, they are also focusing on keeping kids in school. The health of adolescents, educators, staff, and community is really focused on keeping students safe, since not all students will have the opportunity or eligibility to be vaccinated. That's why they put their guidance together. Their first statement is, everything possible must be done to keep students in school and in person. So both of those guidance, really the underlying principle is let's get kids back in school. So primary focuses to consider in decision making. So this is where they really give you different options, and different communities have different considerations. So some things to consider when looking at school guidance, level of community transmission, level of vaccine coverage, use of screening testing, outbreaks, and the age of children that you serve. These are really all of our primary prevention strategies. The guidance goes through each of them individually, so there's not a one size fits all, not a one principle. It really looks at this multi-layer approach to keeping COVID out of school and lessening the burden. So the number one priority, second priority to keeping kids in school is really vaccine. When we look at vaccine, it is our most effective public health intervention at keeping COVID out. 98, 99% of our hospitalizations nationally are all in unvaccinated people. These vaccines are highly safe, highly effective, currently indicated for kids 12 and up, which really is good news for middle and high school. We are looking at Pfizer has completed their trials for kids 5 years to 11. We expect approval to occur in that age group, sort of like October, November, December-ish. As we get closer to that timeline, we'll have a better idea. And then they're studying the vaccines all the way down to children 6 months old. But that'll be the last group that gets approved. So American Academy of Pediatrics also, big highlighted statement here is they recommend all eligible individuals should receive the COVID-19 vaccine. So that's the big statement. They're also highly recommending vaccination. Next point that they talk about in the guidance are consistent and correct mask use. Really point out that people who are not fully vaccinated are highly recommended to wear masks indoors. Outdoor in general, people don't have to wear masks regardless of vaccine status. However, masks should be considered in crowded outdoor settings during activities that involve sustained close contact with other people when they're not fully vaccinated. I think one of the most beneficial sections in masking is really, they add in here Based on the needs of the community, school administrators may opt to make universal masking required regardless of vaccine status, and they give some examples of reasons. Student populations that aren't eligible, schools with kids under 12, increase of substantial COVID transmission. So this talks about, tying transmission to other interventions. Talks about variants. Here we are seeing substantial variant transmission. This morning on the CDC call, the Delta variant is now estimated to be 85% of our cases here in the US. And we are seeing increasing Delta and B117 here in Alaska. A couple ones I think that are really beneficial here is talking about schools that don't have a system to monitor vaccine status of students, teachers, or staff, or difficulty monitoring or enforcing mask policies that aren't universal. Also, awareness of low vaccine uptake within the student, family, teacher, staff, or the population in the community, where they really added on a lot of the national calls they're hearing from districts around the country where parents would be unwilling to send their kids back to in-person learning if they don't require universal masking. This is in the guidance, and it just gives some really good options about when you may want to consider universal masking. This is the one requirement, and this is something that I was actually and I had forgotten about prior to these guidance coming out, that it is a federal order for masking on all public transport, and school buses do count. So there is a federal requirement around the country for all mass transit. They even go as far as to say that, example, if a student attends a school where mask use is not required due to vaccine status, the student is still required to wear a mask on the school bus. So school buses do fall within that federal masking requirement for public transportation. Only thing they really mention requirement in the whole guidance. So here the American Academy of Pediatrics kind of took it a step further. They did recommend universal masking at this time, but they gave some justification for it. So I take it this really supports the CDC guidance as well. The reason is, a significant portion of students are not yet eligible for vaccine. Elementary students under 11 aren't eligible yet, therefore they're all not fully vaccinated. And they really talk about how good these vaccines are, how safe and how effective, and also talk about how difficult it is to enforce mask policies that aren't universal, and also talk about around our country, we have a lot of communities with low vaccine uptake, and then also concerns around the new variants that are more easily spread. Next thing the schools really talk about is physical distancing. And they do add in here that, if you can't maintain physical distancing, that is not a reason to keep kids out of school. So keeping kids in school is a priority, even if you can't maintain physical distancing. Another thing I really want to mention, they do clarify, it's actually on the next, a couple slides later, is around that definition of a close contact in the 3 to 6 foot window. I have another slide on that later. They do talk about that and address it in this guidance because that was always kind of an unknown. Screening testing, they have a really good chart. So screening testing is anytime you test someone who is asymptomatic. Screening testing, they say, may be most valuable in areas with substantial or high community transmission, in areas with low vaccination, or in schools where other prevention strategies are not implemented. So a key takeaway from this is, universal masking may not be applicable for everybody, but that's a key prevention strategy. So in areas where we're not doing universal masking, it would be worth considering doing more robust screening testing. Just thinking about that layered approach where it's not a one size fits all model. Another thing they add in here, to be effective, screening programs should test at least once per week and get rapid results. So we still do have rapid antigen tests here available at the state. Those tests are inexpensive and readily available. We also have rapid molecular testing that a lot of school districts are continuing to use, and I'd be happy to discuss testing options further. This chart, I think, is the most helpful part on testing, and I like that they added a few things in here. It really does a couple things that I want to point out. So it talks about community transmission, low, moderate, substantial, high. And then here's a few things I want to point out. So they defined high-risk sports and other activities. Before this, really, we didn't have a way to define high-risk activities that weren't sports. So in here, CDC is recommending screening testing for all high-risk sports and extracurricular activities at least once a week for participants who are not fully vaccinated, and that's even in the lowest transmission for high risk. For low or intermediate risk sports and activities, and for general students and populations in the lowest transmission, screening testing is not recommended for those who are unvaccinated. Doesn't mean you can't do it. And I really think this chart is very helpful. Thing that I like that they added, it was this section to define high risk extracurricular activities. So aside from sports, those are activities with increased exhalation, such as singing, shouting, band, exercise, specifically when conducted indoors. So they add in some defining characteristics for other extracurricular activities. Ventilation, nothing really new here. Ventilation is a prevention strategy. I think now we've all learned more about ventilation than a lot of us ever knew. But aside from well-fitting masks, bringing fresh air indoors helps reduce viral concentration. Hand washing and respiratory etiquette is nothing new. You know, enforce hand washing and cleaning surfaces. Stay at home when sick. So this is another thing I hope that stays with us from the pandemic. Keeping the symptom-free school policy that we talked a lot about last year really is keeping when kids are sick, keep them home. Same way with faculty and staff. You know, I kind of remind people that the year before COVID, we had an elementary school shut down in Anchorage due to a flu outbreak, and we don't want that to happen as well. Really stressing testing as well for people regardless of vaccine status if they have any symptoms. So even vaccinated people, when we talk about a 95% effective vaccine, that still means 1 in 20 people could develop disease. So really encouraging testing for anyone with symptoms and to stay home until they recover. So this is talking about contact tracing. They still recommend contact tracing. This is where that distance comes in because they do clearly define it. The previous guidance, talked about 3 feet where 6 feet wasn't applicable. A big thing here, though, I really want to point out is they're still saying, 6 feet is that close contact window if you're within 6 feet. However, in K through 12 schools, indoors, that 6 feet is excluded for students who are within 3 feet and 6 feet. So if they're greater than 3 feet but less than 6 feet, if they're unvaccinated, they're using universal masking, and at the time both students are masked, then kids who are in that greater than 3 feet but less than 6 feet window would not be considered close contacts. So I think that's really important. It really cuts down on the ability, on the space needed, and it allows for less known close contacts and really speaks to the beneficial of universal masking in preventing viral spread. Cleaning and disinfecting, pretty straightforward. None of that has changed. A couple other things that they really have a whole section here about sports and other extracurricular activities that talks about, our high risk. Higher risk is close contact and indoors. Team sports, lower risk are outdoors and individual sports. Talks about students who are not fully vaccinated participating in indoor sports and other high risk activities should continue to wear masks and keep distance as much as possible. And I referenced that other chart already that really goes around testing. Another thing that they really talk about here, really give a lot about sports. I encourage everyone to read it. Kind of already going over the consideration for sports. Talks about school workers, considering people who can be vaccinated or unvaccinated, or also thinking about people with medical conditions that may have a weakened immune system, making sure that you take them into consideration. Talked here about all districts recommending that they have emergency plans, what to do and respond to outbreaks, what to do if disease spread increases, what to do with low vaccine rates in your community, to just kind of think about the whole model. Another thing, the last section I'll go over is they do have this part based on vaccine verification, where the recommendations here are all pretty heavy on vaccine rates, because again, vaccine is our best intervention to stop the pandemic. They say here, existing laws and regulations require certain vaccines for children attending schools already. Administrators who regularly maintain the documentation of people administration records already. Since and prevention strategies vary by vaccination status. K-12 administrators who maintain the documentations and workers' vaccine status can use the information the same way when applicable to local laws and regulations. Basically handle, if you're going to do vaccine verification, do it the same way that you do it with other vaccines. Don't treat this one any different, but also be sure to follow local laws and restrictions and regulations. That's all I have. I know it's pretty quick. I assume a lot of people have probably already looked at these. Don't know if anyone else in the team has anything to add, but that's all I have for the initial presentation.
I think people should feel comfortable just unmuting so we can have conversations about this, and we're happy just to talk through any questions or ideas that people have. I see a question on here about sharing the presentation. We're happy to share the PowerPoint to everyone, and Pat Sizemore can probably send that out if that's accurate, Pat. And then someone else asking for a PDF copy of the presentation so we can figure out how to get that to people. Oh, Coleman's just put it in there. Perfect.
Yeah, I think I got it.
It looks like it. So are there certain things in the guidance that we can help clarify, or we can help talk through, or are there specific hurdles or barriers you guys are anticipating after seeing the guidance that you might need more support on? So there's a question. Yeah, from Chris. Do we know if the close contact change in definition has been shared with local public health nurses doing contact tracing? I believe that they're very up to date on all of the definitions for close contact, and I'm not sure if we have a public health nurse on here that can kind of speak to that, but they're very well looped in on all of the contact tracing.
I can make sure that the lead public health nurse, Tim Struna, gets that information out specifically so everybody's on the same page.
Pat's also put in the echoes. Those are starting back up on Mondays. We're going to continue to hold those from 3 to 4 so we can keep the conversation going and keep supporting schools as we move forward into the fall. So Dana has a comment. What about a school board who already voted to not require masks at all in schools? Are they within their power to do that? So that's a great question. I'll have Barb kind of start with that, and then we can fill in.
So a lot of the schools are reevaluating the districts, what they decided in May because of this new guidance coming out, and because of we're seeing an increase in cases throughout our state and the Delta variant. So I've had several conversations that, it is possible, and you probably will want to rediscuss this with your school boards. And we would be happy to support you with the science. We've been invited to school board meetings before, been on a lot of yours, our team. So that's what I'll start out with. And Coleman, you probably have more to add too.
Yeah, I mean, the only thing I'll add is these are new recommendations and new guidance that just came out. So, I mean, obviously, if districts voted on that, they did it without these new guidance into consideration. So I think that was really, really well said, Barb.
There's a question on here about the Delta variant and kind of the risk to those who have been vaccinated. So we are looking at the data closely for vaccine breakthrough cases with the Delta variant. And there's some indication, especially from kind of global international data, that there maybe some increase in transmission. But looking at the Alaska data, we expect to have more vaccine breakthrough cases as we get our vaccine rates up further. So we'll continue to watch this, but there hasn't been a huge red flag in our data so far. Definitely seeing an increase in transmission, and on the new genomics report today, 56% of cases that were sequenced were Delta in Alaska. Again, that's about a 2-week delay. So we are seeing more of that, which is going to be important moving into fall.
Do you think it's reasonable to, so what we're considering doing is kind of basing things on level of transmission, because currently, well, yeah, I think it was the last one. We have had nothing going on for so long, like 0 cases. So that's kind of where we're at, is putting something in our plan that at some level of transmission, that's when we start making the kids wear masks. Or is it too late by then? I guess is the question that I keep asking myself.
If we look at the guidance, I mean, it really talks about that. That's an important consideration. So, I mean, I think theoretically, if we talk about a community that has high vaccine rates and low viral spread, that's a pretty low risk scenario. I mean, obviously, it's always a balance, but that is supported by the guidance, having different levels of mitigation based on what your cases are. Now, like you said, I mean, one thing to consider is, one of the things that has made this virus so tough the entire time is the amount of asymptomatic spread, and the amount how, it takes a while, to once you see cases impacting. But I totally think that it would be completely in line with this guidance to have different strategies based on community spread.
Thank you.
I'm sorry, I have a quick follow-up question to that. Most of our school sites are very small and they're village communities. So even if we have a mask guideline in place, there's a good chance that our students, as soon as they walk out that door, are going to be going to each other's houses, and because they're largely related to each other. So unless they're following the same mask guidelines at home throughout their personal life, at our smaller sites especially, these kiddos are going to be mixing with each other constantly after hours. That's my first concern about it. And second is, as guidelines, I know there was a question earlier about boards voting on what they can do and can't do. As guidelines, is the autonomy still within the board to make that choice? I'm assuming, since these are guidelines and not mandates.
Yeah, the first thing I would add is that's a great point. So, where these are guidelines, they are not mandates. One thing to consider would be, maybe if you don't have great masking compliance in a community, you're talking a small community, then maybe that's not the best intervention. So if you look at through the guidelines, then maybe other ones are ones that you would stress more, increasing vaccination rate, increasing screening testing, increasing distancing. So these are all, it's this multifaceted approach and not a one size fits all model. And it really empowers you, who knows your community better than I do or the CDC, to what's going to work best for your community.
Thank you.
And as to the school board question, is there somebody from the School Board Association that could answer that? We've seen the medical advisory teams being a very important part of school board decisions. And so I would encourage you to make sure you have your local providers and having a medical advisory team available at your school board meetings, because that has been a great partnership to come up with decisions.
And I would just chime in, as a school board association, we always reiterate that it's local control. Take advantage of your experts and data for your region. That's why we're here, to hear from the experts and about the science and stuff.
I think it also helps using them because when you look at like even on that testing chart that's there where they use the however many cases per 100,000 or whatever it is, it's been really helpful for us to use our local health corporation and public health to try to figure out what those kind of numbers mean for our community versus the whole 100,000. Or what community spread really means in our community because of the number of families. And sometimes you can have a lot of cases, but it's really only in one family.
Those are all really good insights. I think Sherry has a concern on here, wondering if other school districts have had concerns about continued decrease in enrollment. Many parents have stated that they will continue to keep their kids out of school if we require masks and or promote vaccinations. We've had some very strongly opinionated parents, board members, and she would love to know how others are handling this. So if anyone wants to share if they're having the same experience and what has worked or not worked for them, that would be great.
I think for Dillingham, we had a big mix. We had kind of a mix last year with people that just didn't want their kids in school. So we had several different options for them. But this year we've really been trying to push and promote that we need to catch these kids up and we need to do whatever we can to keep them in school. We still have options, but like, for instance, here last year we paid for everybody's internet with help from others, but we're not doing that this year. Just really trying to say that our focus, the district's focus, is completely on the kids and learning. And there's going to be some risk involved with that, but we think the reward is worse than the risk at this point, I guess. And here, like I said, we've had really low cases or no cases for quite a while. I think we just got one in the last week, but we hadn't had any for months.
I think the real benefit to the CDC guidance is that it gives you options with that, just as you're saying for Dillingham, where this kind of layered approach gives options. I think it's, if things are going well, you can peel back some layers. If they're not going well, add some layers in. And I think going into the school year with kind of a plan in place that's well kind of disseminated to parents and students will be helpful. So I think the more that we can share ideas together, that will be, useful. I do feel like the guidance that the CDC has put out this year is very science-based. It kind of gives guidance that is easy to follow. So I'm hoping that school boards will consider looking at it. And, really the end goal is exactly what Coleman said. We want to keep kids in school, and this is a great tool to make it happen.
We really tried to stress too that because we wanted to give people hope at the beginning of the year and that things were going to be somewhat normal, or we try to be normal, but at the same time, while doing that, we also wanted them to know that we had a plan for if things started going sideways, and not to let them think, because obviously you have people on both sides, strongly on both sides, about whether you should have nothing or something. And we tried to just make sure that it's very apparent that this can change weekly, monthly, wherever and whenever we need to change it, we reserve that option. And I'm sure everybody knows sports is probably one of the most complicated things, especially out in the bush, because you're going to add travel into that and whatnot. But we even, are putting something in there that says we reserve the right to assess any destination based on what's going on there, but that we'll meet with parents and the coaches and the kids that would actually be going and decide that together. So.
Yeah, thank you for that. And Jamie Burgess, I'm not sure where you're located, but they're also not offering kind of a virtual option and trying to get kids back into schools. And most of their constituents that didn't support mask wearing or vaccinations were in homeschooling already. There's a couple questions on here about vaccine status required by the state. We kind of defer most of these questions to the legal counsel and the state health. We try to stay away from all of that, but again, there's no state mandate for vaccinations at this point and not a plan for that. Within different schools, there can be, different mask policies, but I would defer to vaccination status questions to legal counsel. And follow up to Jamie's comment, she is in Nome and they have good vaccination rates.
There's a question in here about digital reporting. So we have a document for reporting that I can put into chat as well as a PDF file template. But some of the devices do have the ability to directly report through like the state digital reporting system. I can put an email address in there. I encourage you to reach out to Megan Tompkins to see if it's integrated or the individual provider, the machine you're using. So like, for example, some of the Abbott ID Nows have the ability to report digitally, some don't. That has to be really as a question for Abbott. But I think with the reporting guidance, the document I'll put in here, I hope will be helpful.
And Coleman, do you want to talk about the FDA approval process? The question just came in.
Sure. So the first thing I will mention, because this is a huge internet myth, is these vaccines are not experimental. They're not investigatory drugs. They're not experimental drugs. They are approved now. So emergency use authorization is approved by the FDA. There's no additional steps. There's no additional safety measures. It's the same process for an emergency use authorization drug as an approved, quote unquote, approved drug. So in terms of safety, in terms of effectiveness, no difference. The difference is with EUA, they enable a certain group to come to market first. So while you're still studying it in other people. So if these vaccines had only been studied in adults, they weren't going to study them in kids. Or if all the trials were done at the same time, like we would already have full approval. It's sort of just a stamp at the end saying that your trials are all done. So for full FDA approval, one of the requirements has always been that all of your trials are done. So the kids 6 months through 4 years old are the trials that are still enrolling and are still underway. So traditionally, we won't see full approval until that group is done being studied. Now, I do think, based on the fact that there's so much misinformation on the internet, people think that these are investigational drugs, that they're experimental drugs when they're not, that the FDA may meet and give full approval for either kids 12 and up or 16 and up or 18 and up before the studies are done. I doubt that that'll happen before October or November, but it could. So if we go down the traditional timeline, we won't see full approval until the last studies are done. If I had to guess, I think, like I said earlier, that we'll get approval with Pfizer for kids 5 through 11, kind of like more like October, November, December-ish. We'll probably see kids 6 months and up get approval more like next spring, late winter, like January, February, March, April-ish. And then right after that group, we'll see full approval. We could see full approval in adults as soon as this fall. But I think kind of worst case scenario, we'll get a full FDA approval late winter to early spring of next year. I'd be happy to take any more questions on that, but that's where we're at. And I will say on the legal front, Dr. Rabinowitz said it perfect, that we are the Department of Health. So we don't really make recommendations on that, but the way we're to understand it is that's an individual question for your human resources and your legal department. Some businesses here in Alaska are requiring vaccine as a condition of employment, and some businesses are requiring vaccine verification for certain things. We're not requiring anything at the state. We won't be requiring anything at the state, but for an individual organization, you are able to do as your legal and HR team sees fit.
I can't remember if it was in the CDC guidance or not, but there was some talk about pooled testing. And I think in a previous echo, you said that there were no sites in Alaska labs in Alaska that could do the pooled testing. Is that still true, or process it?
So I do believe that Beech Tree, which is the one commercial lab here in Alaska, has validated pooled testing. There's a lot of labs outside of Alaska doing pooled testing. Capstone, who's the other commercial lab here in state, I believe are validating pooled testing. Pooled testing, it does, in the CDC guidance, it does talk a little bit about different testing strategies. In general, pooled testing is more beneficial when you have a lot of people to test, but you could use it for smaller groups. So the concept of pooled testing is you basically get like 10 people or so, whatever the number is, you swab all of them, stick it all in one vial. And then if it comes back negative, all 10 of those people are negative. If it comes back positive though, you have to retest every individual that was in that group. So it's a way to cut down cost and also do a little bit different things with, it enables you to get more surveillance. The other interesting thing, and I'll be happy to put it in chat, is there's a company out of Oregon who's doing surface testing for surveillance. So where they can't pick up individual cases, but they can look at trends. So, through their surface testing, they can find out, hey, we had a 20% increase, then that might be a reason to do more individual testing. I got a few documents from them. I'll put those in chat as well if anyone is interested in that.
And again, as Coleman's mentioned, we're always happy to do one-on-one kind of sessions if people have more detailed questions about testing and different protocols that could work for your schools. We're always happy to set up a meeting and kind of talk through those as well. Pat, any other specific questions that have come in through you?
No. I see another legal question, but I suspect you'll refer that back to the legal folks about liabilities to organizations associated.
Yeah, and Dr. Medoff put a nice link in there to kind of direct people. But again, yes, definitely need to speak with your HR and legal department for that. Yeah, I mean, I think as we move forward into the fall, depending on what this Delta variant does, we're all going to have to just move forward with the guidance and figure out what's going to work best for your school, and just know that we're here to support you as you go through this, and we're always happy to share new information. There was a question on how often we'll kind of update on the Delta variant. We'll now have the school echo back in place every Monday, and we'll continue to give epidemiology updates for that. I also really encourage people to go to the Wednesday Science Echo, where we answer a lot of questions about everything COVID and COVID related. So that's another good resource to kind of engage in. Coleman, anything else you'd like to add?
From Delta, I saw a question. I don't know if we answered it. If we did, I apologize, about, vaccine effectiveness. So the way it looks, I mean, the vaccines are still fairly effective to all the known variants. So this morning on the CDC call, they reported out that Delta is now 85% of the cases here in the US. There are places in the Midwest that it's over 95%. We have a new sequencing report coming out here today, but it's I think after that, it's going to be more than half of our cases here in Alaska. You know, in the UK, Delta took over to pretty much 100% of their cases very quickly. It looks like Delta is a lot more transmissible. You know, it's easier to transmit from one person to the other. That's what's making it particularly taking over quickly, is that it's easier to spread. So, you know, that's where we're at. We are seeing pretty widespread Delta through most of Alaska now, especially our urban areas, you know, and also in our remote areas as well.
I think the important thing to note with that, as Coleman said, we do have vaccines, they work, but really finishing that full series. So the second shot of your mRNA vaccine gives a significant increase in efficacy, especially with the Delta variant. And then also a lot of questions that we continue to get around, you know, what kind of protection do you have after infection? So we know that 90 days after infection, you still have pretty decent protection. But then after that, we really recommend people do get vaccinated, because you get higher level of coverage with the vaccines and potentially longer coverage. So we just really want to encourage communities and schools to, as they talk to their communities about vaccines, to encourage them.
Yeah, the other thing I'll add to natural infection is there's a lot of variability as to how much immunity someone receives, and we don't really have a way to measure that. So, you know, where, you know, 4 of us could be infected at the same time in the same place. One of us could have pretty darn good immunity and could have almost none, and there's no way to really gauge that. So really encouraging, you know, vaccination is the way to prevent variants, and the way to, even in those who have been previously infected.
There is a question on here, other diseases where vaccines are recommended for the 2-month to 11-year-old children. There's quite a few vaccines that are recommended for that. I don't know if we have a school nurse on that wants to run through the vaccine schedule, but there's a lot of childhood diseases that we cover with vaccines. And then I also wanted to see if Dr. Medoff had anything else that he wanted to kind of add in. He's going to start helping with schools as we move into the fall. Just to put you on the spot, Sarah. I guess that's a no. And Coleman did put in the vaccine schedule just for the other childhood diseases that we do cover.
You know, another thing I'll mention, because we get so many questions about this, it's important to remember what vaccines do. So when we talk about drugs, you know, vaccines are essentially a drug. They go through the same FDA approval process as all other drugs. Vaccines are different, though, than drugs that we really take every day, because what they do is they teach your body to do something. So I think of them as exercise for your immune system. You know, they teach your body to follow a natural process. When we look at vaccines, a lot of people think, well, if they protect me for a long period of time, they must be in my body for a long time, but they're really not. So with these mRNA vaccines specifically, they're only in your body for 2 to 3 days. After 3 days, they're 100% gone, 100% eliminated from your body, never to be seen again. So in vaccine trials, interestingly, all of them, you know, emergency use or not, and we only study adverse events for 2 months, because we've never seen an adverse event from a vaccine that happened more than 13 days after the vaccine was administered. You know, these are drugs you get one time, your body gets rid of them very quickly. The reason that we follow vaccines for long periods of time in clinical trials isn't because we're worried about some adverse event coming up months later. It's to know how long they work. So that's kind of another thing to consider when we talk about vaccines, you know, and I put in the CDC schedule, you know, there's a lot of vaccines that are recommended for kids under 11, you know, from starting at birth, 1 month on.
And we also have Patty Owens on. She's our kind of directing the new Office of school health and safety. I don't know if there's anything additional you wanted to add, Patty?
Thanks, Lisa. We don't have a new office yet, but we are working on a collaborative between the Department of Education and the Department of Health and Social Services to strengthen our school health and safety programs. The one thing I just wanted to comment at the end is that the CDC recommended vaccines may differ from the Alaska school required vaccines. So there are some that are required and then others that are just recommended.
Perfect. Thank you for that, Patty.
Yeah.
And another question in here about boosters for COVID vaccines. And so there's been a lot of this in the media right now in terms of boosters and the need for boosters. There's kind of two things that we look at for deciding on whether boosters are needed. One is if we start to see a significant waning in immunity after being vaccinated. The other is to kind of combat variants of concern or interest that start to kind of become less affected by our current COVID vaccines. Currently, what we're seeing for most people, the COVID vaccines that we have available, they're very effective. All the variants take a little bit of hit off the efficacy, but still with the Delta variant, we're seeing good efficacy. However, there are some subsets of the population, such as immune compromised or transplant patients, some elderly individuals that can have a decrease in efficacy or kind of the antibody response that they get. And so the ACIP is meeting on Thursday to kind of talk through more of that data that they've received from the drug companies and the trials that are ongoing, in addition to other kind of real world data, to make a decision on boosters. So currently boosters are not recommended or authorized, but there may be some new information coming out in the next week or so, and we will definitely update you on that. Pat has also put in a link. Oh, that's for our school echo on Mondays again. Yeah, just to remind people, and please register and come to those. I think they're helpful.
And I put in the required vaccinations for schools.
Perfect.
Yeah.
Cami, from your perspective, anything that you'd like to add in as we kind of discuss this further?
I don't think so. I think just thanking you all for joining us and reminding you that both DEED and Health and Social Services are here to support you. So reach out if you have any questions, and hopefully we'll see some of you in June of next week.
I mentioned we'll take the recording and send it to the Council of School Administrators and the Association of Alaska School Boards so that they can send out the link to that recording of this session to your members. And again, like Dr. Rabinowitz said, we'll be back next week at this time specifically for school leaders and then the ongoing echoes. Are there other questions?
So no more questions. We'll wrap it up for today, and we'll be back with everybody next week. And feel free throughout the week, if there's things that come up, email us, reach out anytime. We're happy to help.